Hi, thanks for joining us today. My name is Grace Kucher, and I'm a physical therapist in the greater Atlanta area, and I'm presenting today on behalf of myself and Dr. Shilpa Krishnan. The title of this project is Clinician Perspectives on Assessment, Prevention, and Management of Pressure Injuries in Skilled Nursing Facilities. Pressure injuries are an important topic of research, not only because they negatively affect the quality of life of those that develop them, but also they're a quality metric for CMS within skilled nursing facilities. So skilled nursing facilities have to evaluate their patients upon their transition over from acute care, and then they document new or worsened pressure injuries on the MDS, or the minimum data set. This information is then published publicly online and contributes to the 5-star rating system for skilled nursing facilities. Additionally, at this point, there isn't a ton of literature looking at the multidisciplinary team that contributes to pressure injury care, and especially if we look within skilled nursing facilities at the short stay component compared to long-term care. Considering the minimal multidisciplinary literature looking at the pressure injury care process, and also considering that other literature shows that pressure injuries are still occurring within skilled nursing facilities, it's important to ask ourselves why this is happening. This picture shows the knowledge to action process, or some people might call it knowledge translation. So you're taking a question, you're going through the research, you're generating an answer, and you're synthesizing this down into a product that can be used within the clinic. So maybe in this case, a CPG for pressure injuries. So discussing the best prevention and the best treatment options for these patients. And then you're adapting it to the local context. And as you continue along this circle, it feeds back into itself. You're monitoring use, evaluating outcomes, changing the process. And we have very little evidence right now for barriers to knowledge use at this multidisciplinary level. So this project is helping fill some of those gaps to understand why, even though we have these guidelines and an idea of what best practice looks like, are we still having pressure injuries in the patients within skilled nursing facilities? So considering the current state of the evidence, the purpose of this project is to explore skilled nursing facility clinicians' perceptions and experiences concerning barriers and facilitators for pressure injury assessment, prevention, and management. The current sample size of this project is 7 individuals, including a variety of professions from OT, PT, physician, nurse practitioner, and doctor of podiatric medicine. This project is still in a recruiting phase, and we are looking to continue to speak with nursing staff, including registered nurses and CNAs. The mean age of the cohort is about 40 years old, and most of the participants were female. Additionally, most of the participants identified as Asian, with a very wide range of years of practice and a geographic diversity as well. Inclusion for this project required that the skilled nursing facility clinicians have experience within the past 10 years, which allows them to fall after the start of the IMPACT Act, which made pressure injuries a quality metric for CMS. All of our interviews were conducted virtually via Zoom. They were recorded and then transcribed using NVivo 12 for thematic content. Next, I'd like to talk about some of our results. So looking at a summary of the themes that came out when reading over the interviews. So due to time, we can't cover all the themes that we found within the interviews, but have highlighted a few of the main ones. The first one I'd like to talk about is the clinician's perceived role in pressure injury care. So we asked them what they saw as their role in both assessment, prevention, and management. And as you can see, that percentages are pretty high. Most people felt like they were involved in all 3 areas of these care. Looking at assessment, people felt they performed visual inspection of the skin, they reported staff communication, and that they assessed function. Interestingly though, One of the OTs indicated they had minimal role in assessment, and one of the OTs said they didn't participate in assessment at all, which is quite interesting. Moving on to prevention, people felt they provided education, they used equipment, like positioning equipment, to help prevent pressure injuries, and then that they participated in actual positioning of the patient. And similarly, we had clinicians, including an OT and the nurse practitioner, who felt they had minimal role in prevention. And then the MD felt they had no role at all in the prevention part of pressure injury care. And then finally, moving down to management, again, we see a high level of staff communication. And so between this and assessment, that's great to see. We know that a team that communicates well is going to be able to prevent, assess, and manage pressure injuries better. Additionally, the positioning rate is higher here than it was in prevention. So people felt once the pressure injury was present, there was more consistent participation and positioning of the patient. And then finally, during management, there was identified by the clinicians a participation in some sort of team rounding, going around and talking with the team and with the patients about their pressure injuries. And then the people that felt they had minimal participation in management were the therapists. So we had one OT and two PTs felt they had minimal role in management, which as a PT is interesting because I consider positioning participation in management of a pressure injury. And also within our scope of practice is a lot of the modalities, but most of these clinicians did not participate in modalities or any sort of debridement. Next, moving on to barriers for pressure injury management, we broke these down into facility and patient level factors. So more clinicians identified facility level factors than patient level factors as barriers for pressure injury management. So looking at the facility, they identified lack of equipment as a barrier to pressure injury management, and this included everything from offloading cushions to a special bed to basic wound care supplies. The clinicians felt that there was limited staff education for pressure injury management, and also they identified a negative workplace culture. They used terms such as disengaged or apathetic. There was lack of follow-up and poor documentation that all made it challenging to manage pressure injuries. And then looking at the patient side of things, 29% identified a lack of patient motivation, that the patient wasn't participating in proper turning or offloading, that they weren't willing to participate with therapies, that sometimes when the patients have more pain, it makes it more challenging to reposition appropriately and again participate with therapies. And then a limited family advocacy, not having family around who is actively checking in on them or following up on their care, was a barrier to pressure injury management. And then finally, we asked the clinicians, what do you feel could be done at your skilled nursing facility to improve pressure injury assessment? Most people, 43%, said that staff education, having a better understanding of what went into pressure injury assessment, prevention, and care would help improve pressure injury assessment. 29% felt that more efficient documentation, such as having more information tracking healing times, using pictures, having less mindless clicking, would improve the pressure injury assessment process. And then 29% said increased staffing would allow an improved pressure injury assessment process. So continuing on with some of the themes, the next question we asked was if clinicians felt that their skilled nursing facility had a wound care team. And 71% of participants said yes, their skilled nursing facility did have a wound care team. The most common clinician leading this team was the registered nurse, followed by physicians, and then the most common member of the team was also the registered nurse, followed by an LPN, nurse techs, a wound physician, and then only one individual identified therapy, including PT and OT, as a member of the wound care team, and then one physician's assistant as well. The next question was, who is most responsible for pressure injury management? So in this question, we had participants rank several different players, including nursing, specialized staff, including your physician, and then therapy, the family, and then the patient. And we said, who do you feel like is most important? And most, 86%, ranked nursing as number one. And then 40% had the CNA or the LPN, so the nursing assistant, not a full RN, as number one, which is super interesting. So they're saying of all the wound care team members, the nurse or the nurse tech has the biggest role to play in pressure injury management. And often the patient was ranked either last or second to last to the family. And when I asked them why they felt this way, they described cognition as a huge barrier for the patient's involvement in pressure injury management. So when a patient doesn't have the ability to recognize the need to turn, that they don't play a role in this pressure injury care team. And again, this is super dependent on the population. So all of our clinicians are working in different areas of skilled nursing facilities. They're treating different patient populations. But the majority of them felt that cognition was a significant limiting factor for the patient and their role and participation in pressure injury management. Next, we asked clinicians to rank themselves on a scale from 0 to 100% and how they perceive their own ability to assist in pressure injury prevention. So this is pressure injury prevention. This is just making sure they don't get it. So turning, offloading, assessing the skin. This isn't a crazy intervention that's required. The mean number reported was 69%. Clinicians gave themselves a D+ for being prepared for pressure injury prevention. And most of them, 83%, identified wanting further pressure injury education in order to improve this to 100% prepared. They felt like their schooling and the education that they were given through the facility wasn't enough to prepare them to effectively help their patients prevent pressure injuries. And then finally, coming back to this topic of education, does your workplace provide specific training for your role in wound care? 71% of participants said no, that there wasn't a specific course or onboarding expectation that helped them understand their role in the wound care process. Most of them identified some sort of intermittent in-service, and this was mostly nursing staff or point of care staff-to-staff education. So in the moment, the physical therapist is doing some positioning and explains to maybe the tech or the nurse what the best way is to help transfer or position this patient. But they all felt that education, as we talked about earlier in the previous themes, is a barrier to improving pressure injury assessment. And then finally, I've just included a quote from one of the participants that CNAs are tightly scheduled. They are sometimes overwhelmed with their existing duties. And if they have positioning as an extra added duty that takes up a substantial amount of time, then it gets burdensome for them. And I think this quote just highlights some of these themes that we're talking about, that there are a lot of different barriers for pressure injury management, assessment, and prevention in the skilled nursing facility, that clinicians are pulled in a lot of different directions, that if priorities aren't clear, it can be easy to let pressure injury management sort of fall towards the bottom of the list, which isn't good for patient outcomes. And the role of CNAs is something that came up during these interviews as well, that CNAs have a very high involvement in this process, but often don't have the training to support it. And so I think that's something very important moving forward that we begin to discuss and address as clinicians. So finally, our discussion. What does all this information tell us, and how can we apply it to our practice going forward? So I think the first and biggest thing is that pressure injury prevention and care is a multidisciplinary process, right? We're interviewing all these clinicians and having them working together, communicating well, having a strong leader, having accountability is important to the success of this team and to guaranteeing good outcomes for the patient. Ideally, pressure injury prevention, but if the person does have a pressure injury, maximizing the ability of that pressure injury to heal. Next, looking at documentation. Using appropriate technology, including photos and more streamlined documentation, has been shown to improve wound care. So looking at facility-specific concerns and figuring out how we can address the clinician's concerns and make documentation useful for them and efficient for them. Next, looking at staffing. This was a huge concern across most of the participants, that the staffing just wasn't high enough to support the needs of the patients. And so even though this staffing is a quality metric like pressure injury is for CMS, we found a lot of variation in the SNF staffing levels. But we know from previous research that low staffing decreases quality of care and can even increase adverse events. So figuring out how to appropriately address staffing moving forward is going to be important to optimizing our outcomes. Next, the theme that came up often throughout our discussions is that clinicians feel they have inadequate pressure injury education and training, and that they need to be better equipped to improve the patient's health and help manage their pressure injuries or prevent them in the first place. A lot of the current literature looks at nursing education in particular, and I think moving forward it would be helpful to have some sort of assessment for the other clinicians involved in wound care as well. And finally, CNAs have the least education and very high turnover rates, but are responsible for a large portion of patient care. Really having a team, a wound care team that values the work of the CNA and supports them and encourages them to communicate with the RNs and the other clinicians is going to be a huge way to improve outcomes moving forward. There is some literature at this point looking at different CNA training programs, but obviously none of the clinicians I interviewed talked about them, so they aren't being implemented well across the country. So that could be another area to address and assess moving forward. In conclusion, variability exists across clinician and skilled nursing facility in pressure injury assessment, prevention, and management patterns. The barriers to effectively prevent and manage pressure injury occur at both the patient and the facility level and include insufficient education, low staffing, and poor workplace culture. Though variability exists, future studies need to help elucidate the cause. What is the root cause of this variability? Is it the clinician? Is it their practice patterns? Is it their personality? Is it the facility? Is it the state in which they practice, or different laws and regulations that are held specifically to them? So moving forward, having a better understanding of the root cause of this variability will help us address this and help maximize patient outcomes. Next, I'd just like to make a couple acknowledgments. First to NIDLR for their grant support of this project, and second to Emory's Neurologic Physical Therapy Residency and my research mentor, Dr. Shilpa Krishnan, for her support in the completion of this project. If you'd like to contact us, please feel free to email us at the addresses included below. And thank you again for your time and attention, and have a great day.